Thank you. Thank you for giving me the opportunity to speak with you today and to share some of the work that we've been doing at the Walton Centre, but also some of my thoughts as well. So if we can move on, please, Georgina. So what I want to talk to you today about is to discuss the approach to commissioning neurological services, which has changed at pace, is all I can say at the beginning, since January this year. In relation to commissioning neuro services, what information do I need as a divisional director? And what information do I need from my partners? To acknowledge the challenges that are in neurology currently and also within the commissioning process. To talk a little bit about how we engage, and that is engage with partners, our other acute services, as well as our patients and carers, and then to explore the future opportunities that we've got in this rather strange world that we're living in at the moment. Next slide, please. So just on the commissioning landscape, pre-COVID, my service commissioned with specialised commissioning, the CCGs, NHS England, and others. Now, other is in relation to how we set up our services in Liverpool, because it isn't just for Liverpool or for Cheshire and Merseyside. We also provide services to the Isle of Man and into North Wales, and they're a very different commissioner and different commissioning styles to NHS England and specialised commissioning. And pre-COVID, we used the tariff system or payment by results. And this was useful in some circumstances, but not useful in others, because different tariffs were in place across the country. So what I was being paid to deliver my service could have been considerably different to what other services were being provided in, say, London or Lincoln or places like that. However, it did give us the chance to grow our services, so we could look at our service developments and we could look at our business cases and we could look at the demand that was coming in, and we could use that demand to actually fund the way that we could provide our services in the future. So in a way, we could sort of grow ourselves out of problems, but we could also grow our services because we were able to get funded and to get payment for what we were actually doing. Then COVID came along during its first wave, because obviously we're now into the second phase of this now. So COVID came along and we all moved very quickly to what was called a block contract. The block contract was based on what we did last year, so the numbers of patients and the care that we provided last year, plus a percentage top up. What that means is that you get paid whether you do it or you get paid whether you don't do it. But what it doesn't give you the opportunity to do is to actually work with the commissioners to develop your services, increase the numbers of patients that you're seeing and get paid for that. So we've had to find a way of developing our services and being much more innovative in how we can provide different types of services in a different way, and how we can actually continue to develop our services and put additional resource in there. And what we're moving to now is what they're calling the block payment plus a bit more, but we don't actually know what that looks like. And post-COVID, or post-April, I should say, not post-COVID, post-April 2012, nobody knows what this commissioning landscape is going to look like. It changes by the minute. So this is bringing and providing us with some real challenges in how we can actually move our services, keep developing them, and ensure that we're providing the right services in the right place in the future. So it is a process of actually trying to be more efficient and using our existing resources in a different way. Next slide, please. Of course, we can't move on without looking at what happened through COVID and what we had to do, and in fact where we are now in relation to reviewing our services and actually restoring our services. So we've been heavily changed and governed by regional command and control, and to some extent a central command and control. And I'm sure, like a lot of you in the room, you were also having your own trust and command and control. And this has been put back in now because obviously we're still in the lockdown situation. So with that, we lost the ability to provide the services the way that we wanted to provide them, and we were very much dictated into how and what we had to provide. That meant that a lot of our services stopped during the first phase of COVID. So in relation to that, we had to undertake risk stratification in all areas, look at our pathway management, and look at how we were actually providing advice and guidance and actually triaging those referrals that were still coming in. And we had to rely heavily on information technology to do this. And I think in the future, data and information technology is going to be even more important than it has been in the past. And we had some particular challenges in our Cheshire and Merseyside area due to the way that we provide our services, because we provide them on a hub and spoke. So the Walton Centre itself in the north of Liverpool is the hub, and then we provide satellite services to all our acute trusts. So of course they were also in a command and control situation. So not only did we have to sort out our own services on site, we had to negotiate and work with every single one of our acute providers to make sure that our patients and our staff were safe when they were going into those areas as well. So significant challenges in that area, which has certainly made us think about what is the right model and what do we need to do differently, particularly moving into what is going to be the new normal. Next slide, please. So in relation to commissioning neurology services, what do I need to have in front of me to make those logical decisions about how my services are going to look next year? So one of the most important things to me is getting patient feedback and understanding what the patient needs, what the patient wants, and how we can actually sensibly provide that going forward. I need to look at what we did last year. What was last year's outturn? What activity did we undertake there? And this is bringing me significant challenges now to how I'm going to be developing services next year, because this year has looked considerably different. So we don't actually know what the numbers are that we need to deliver next year, because we've been artificially dumbed down really this year. I also need to look at the local demographics, because as I said previously, I don't just provide services for the local area. So it's far reaching. It's a 3.5 million population, which covers Cheshire, Merseyside, North Wales, the Isle of Man and beyond. And also looking at what's happening around public health and inequalities and the deprivation. And I'm sure we're all well aware that those inequalities and the issues with deprivation have come much more to the front with COVID, and how COVID has actually impacted upon our patients with neurological conditions. I also look at what research and innovations going on out there. One just mentioning there is the National Audit of Seizures in Hospital. And that's actually made us look at where and how we provide our services, going back to the inequalities there. So we've actually taken our consultant epilepsy services out into the deprived areas, into the community where it's most needed. Complaints and concerns give us a wealth of knowledge. You know, most people look at these as a bit of a negative. I look at them as a real positive. You know, they give me themes, they show me where we're doing things right, they show me where we're doing things wrong, and they also show me where I've got some real issues within certain areas of the service there. And then from a clinical perspective, you know, I'll speak to my clinical colleagues, my medical colleagues, and we'll discuss what new drugs and new devices are coming on board and how they're going to affect us in the future. And particularly around headache and MS, there's been an actual plethora of new drugs coming out, which has provided us with some significant challenges in relation to capacity there. And of course, Garrett's going to speak about GIRF later, but we've had our deep dive GIRF review, and it's really given us food for thought. It's really made us look at how we are providing our services, and I'll come on to that in a little bit later. But it's really made us think about, you know, what do we need to do differently and what will that look like? And that also links into the right care as well. Next slide, please. So what are the challenges that are associated with commissioning, and how, you know, me particularly as a divisional director have to take our services forward? So those challenges are around the timescales. Usually by this time of the year, we've been working up our activity plans, working up our business plans, working up our business cases, presenting them, discussing them, taking challenges back, negotiating, etc. We've done none of that this year. That's really worrying for me, because I know that all of a sudden I'm going to be asked, what are you doing about next year's activity and taking your services and your business forward? We've got a workforce that is tired. They are demotivated to some extent. So we need to think about how we're going to support those people taking our services forward. And patient behaviour has changed. They want us to provide things in a different way. They want to be seen in different formats, and we've embraced that. But also some patients still don't want to come onto the hospital site. So how do we provide services to those people? I talked a little bit before about data, information and analysis, and that leads on to financial analysis. It all looks very different this year, so significant challenges for us. And transformation and change management skills, we've had to move at pace here. We've had to look at what that does to the culture and how we manage the anxiety in the system there. But there's not a lot of us that are really skilled up and trained in these, significant transformational change skills. Next slide, please. So one of the things that's really important to me is how do I work with people to develop services? And to me, it's very much about working in partnership. And we've had some challenges with that recently. It's how do we actually work together in these different forums there? And I think we've very much got to look at, how we can use people that are already surrounding us and supporting us, like our governors in the hospital, our support services and the third sector. The use of surveys, we're in the middle of inpatient survey and outpatient survey results again there, really using those and seeing what they're saying to us. I have a service, it's the Integrated Neurology Nursing Service, and these work out in the community across all areas in neurology. And these nurses are really bringing back some important information for me to use in future commissioning there. I think it's really important as well to meet with people who are using our services. That's not just patients and carers and people, but also on our acute sites as well, and other clinicians there, to help them understand the commissioning process, but also to help them to understand what the service can actually offer in a realistic way. And in relation to local support groups, it's about going to them, being visible to them and working with them and helping them, helping us with them to develop the patient pathways and have everybody involved in that service redesign and pathway development. And only then will we get a true informed future service model for what neurology will look like. Next slide, please. So what opportunities have come from this different way of working? It's around working in partnership. And that's working in partnership with patients, carers and people who use our service, but also clinicians and operational teams. And I've had an interesting meeting just at the end of last week, which showed to me that people really don't understand that working in partnership, particularly from an operational and a clinical perspective. We need to be on the same team now, even more than we ever have been. And it just didn't feel quite right at the end of last week that was what we were there for. At the end of the day, we're there to provide a really good service with the best resources we've got to our patients. I'm working very much now with our commissioners. I'm not quite sure what that commissioning landscape is going to look like going forward, but we need to be working together. So just going back to what I was talking about in relation to what Gerth was showing us. One of the areas that we've started to look at is how can we support the system wider to get our patients with acute neurology in the right place there. So we're looking to develop a rapid assessment neurology area and service there, starting off in the beginning with our Liverpool close hospitals, but then moving it out and taking that assessment area out there. And I'm sure a lot of you have heard of PIFU, or the patient-initiated follow-up that is being supported by NHS England here. I think we need to be really careful with this, in that this is around shared decision making, and in neurology we need to do it differently to how it's been done in other services. And I can't emphasise that enough. And I think there's a lot of anxiety out there, particularly with our support groups, about what that means. It isn't just about finding a way to cull your follow-up waiting list. Rehab's an area of concern for me. The referrals have significantly decreased coming into rehab. We need to look at how we can get people to be using our rehab services there, and particularly with what might happen around long COVID. And I'm fortunate because I've got a work stream with our Cheshire and Merseyside Health and Care Partners, our integrated care system there. And I do think that this is the only way that we're going to be able to take our future commissioning arrangements forward. So I would stress to anyone who's involved in anything to do with service development or developing your business cases or your activity, to make sure that you can get on your integrated care system agenda and make sure that they know what we're doing from a neurology perspective. Next slide, please.
Julie, it's David here. Oh, perfect timing.
And any questions? I didn't time it, honestly.